The last chapter in this set will be Sedative-Hypnotics, Chapter 15. For introduction, they're on page 117. There's three categories that we're going to look at: benzodiazepines, benzodiazepines-like medications, and barbiturates. These are going to be help to induce a sense of calm and decrease anxiety. The hypnotics and are CNS depressants that will induce sleep for people. So most of the time, the most common categories that we're going to use are benzodiazepines and the benzodiazepine-like medications. The reason why is because the barbiturates can cause tolerance and dependency. So remember, tolerance is when you start taking the medication and then you take it for over a long period of time. You build up that tolerance to where you're no longer getting the effects from the medication. So now we have to increase that medication to get the same effect as we did at the lower dose. And then also they have multiple interactions. They're more powerful of a respiratory depressant as well. And then the last category we're going to talk about is IV and anesthetics, which is your non-opioids and your opioids. These are going to be introduced for induction of general anesthesia. Most of them have a quick onset of action and short duration for these two categories. Okay, so your benzodiazepine, I know you guys are going to be overwhelmed by looking at the list here, but remember, a lot of these we have already talked about in the previous chapters, except for maybe some of the ones that we are using for sleep now. So the drugs we have is diazepam, lorazepam, alprazolam, lorazepam, midazolam, tenazepam, clonazepam, and then oxapam, which the Restoril and the Cerax are the ones that we use most of the time for sleep. Okay, so the benzodiazepines enhance the action of the GABA in the central nervous system. Anxiety, we can use it for anxiety disorders, insomnia, and then induction of anesthesia and preoperative sedation. So like your Valium or Ativan, they can give for that operatively. So complications you're going to have to watch for are CNS depression, lightheadedness, drowsiness, and coordination. So we just need to watch for these manifestations, have the patients watch for them at home, and notify the provider. Make sure they don't do any hazardous activities such as driving, operate machinery, equipment, until they know how they're going to react to the medication. Then paradoxal response, this is going to be the opposite effect. So instead of causing them to become sleepy and be able to sleep, it's going to cause the insomnia. Instead of having a more of a depressed kind of a feeling of anxiety, to decrease that, they're going to have excitation, euphoria, anxiety is going to be worse, and then rage. So if any of these occur, you just need to have the client call the provider. Nausea, vomiting, anorexia. This medication can be taken with food. Respiratory depression, especially if it's given IV, you need to watch that more closely, monitor their vital signs more closely, and then make sure you have your resuscitation equipment available. Physical dependency can occur. Benzodiazepines are the lowest abused, have the lowest abuse potential than the barbiturates or any other CNS depressants. Withdrawals following short therapy can be anxiety, insomnia, tremors, dizziness can occur. In long-term therapy with benzodiazepines, their withdrawals can manifest as delirium, paranoia, panic, hypertension, seizures. So once again, we just need to decrease these medications over a longer period of time and slowly. Acute toxicity, orally, they're going to be drowsy, lethargic, confused. IV, this is when you're getting into the respiratory depression, cardiac arrest. So with the oral, You may have to, patient may receive gastric lavage, or activated, followed by activated charcoal or saline cathartics. And then the IV administer flumazenol to counteract those sedations of the benzodiazepine. So what are you going to do as you're giving all this stuff? You're giving the medicine, you're giving a an antagonist to it. You need to monitor the vital signs. You need to maintain airway and provide fluids to maintain that blood pressure. And then have your resuscitation equipment available at the bedside. Benzodiazepines are pregnancy risk category D and X. Contraindicated in people that have sleep apnea, respiratory depression, organic brain disease, or that is breastfeeding, because it comes through the breast milk. Precautions: substance use disorder, liver function, or kidney failure. Older adults, because they're going to be more sensitive to these medications. Interactions are going to be other CNS depressants. Nursing considerations. Oral route versus IV if you can, because one, you're not going to have the respiratory effect as much as you're going to have with the IV. The diazepam, midazolam, and the razapam you can give IV. If we're going to do an IM injection, the razapam is going to be the choice agent. Tapering, we need to make sure we don't just abruptly stop this. They need to be tapered off of it. It can be administered with food. If somnia is occurring, then have them take it 15 to 20 minutes before bedtime. And there is some possible dependency for longer use. So during and after treatment, so just make sure that they notify their provider if this occurs. Non-benzodiazepine, this is Ambien, zolpidem. This is also used for sleep. It enhances the action of GABA in the central nervous system, management of insomnia. Complications, daytime sleepiness, lightheaded, and headache. Pregnancy risk category C. Breastfeeding as precautions, sleep-related complex behaviors, impaired kidney, liver, or respiratory function. Interactions are going to be your CNS depressants. Nursing considerations, give it at bedtime. You're giving anything for sleep at bedtime, you need to consider the onset of action, because if sometimes if something's not going to onset within 30 minutes, do you want to give it at 7 o'clock in the evening? No, we want to give that closer to 9 o'clock. Typically in the hospital, when we have these patients, they didn't get any kind of medication like this after midnight, because then the sleepiness continued on into the next day if we gave it too late into the night. This can be given orally or sublingual. Be administered by. Melatonin agonist, Ramelton, is activation of the melatonin receptors. Once again, management of insomnia. Complications, sleepiness, dizziness, fatigue, hormonal effects, amenorrhea, decreased libido, infertility, glattorrhea, which can cause by the increase of prolactin. Notify the provider if any of these occur. The medication may just have to be discontinued. Contraindications and precautions: pregnancy risk category C, lactation, severe liver disease, apnea, COPD. And precautions: moderate liver disease, Interactions, your high-fat meals, it's going to interfere with the absorption. Fluvoxamine, CNS depressants, and nursing consideration. They need to take this 30 minutes prior to bedtime. They need to take it on an empty stomach. And then it's going to induce sleep is the purpose of this. It is not prescribed for sleep maintenance. It's just to help get them to go to sleep. Okay, intravenous anesthetics. Your non-opioids are your midazolam, diazepam, lorazepam, propofol, which is your Diprivan, and ketamine, which is your Ketalar. Diprivan is the Michael Jackson drug that we use a lot of times to keep our patients sedated when they are intubated. We will use that drug. It's like a white, thick, milky, and it comes in a bottle. Intravenous opioid drugs are your fentanyl, your morphine sulfate. The action is the loss of consciousness and elimination of response to painful stimuli. Complications are any respiratory and cardiovascular depression with high risk of hypotension and shock. So we need to make sure we monitor vital signs in an ECG. So make sure you get that for baseline. This may require mechanical ventilation during the procedures. And then make sure you just have your resuscitation equipment on hand just in case you need it. History of mental health illness. Midazolam can be given to children. Contraindicated. We give it to children in day surgery as a liquid to kind of just help them relax a little bit. Older adults, status asthmaticus, kidney and hepatic failure, and alcohol intoxication. Precautions is respiratory and cardiovascular disease, interactions, CNS depressants, CNS stimulants, and your nursing considerations. You want a slow administration is required for moderate sedation or neonatal anesthesia. This is going to be administered over 2 minutes. You need to monitor during and after for moderate sedation, for respiratory arrest and hypotension. When injecting propofol into a large vein can decrease pain at the injection site. And then instruct the client to arrange for a ride home after an outpatient procedure. We never let them drive home after an outpatient procedure. Even if they're only under for 10 minutes or so, they still don't get a drive home because they're going to be impaired to a point.